Good afternoon, everybody. I welcome you all in the CGR, where this is the topic is surgical blasphemy in hand surgery. So, first of all, let's just go into the brief history how these blasphemy words come into my mind. Actually, if you remember, this famous scientist in the 15th and 16th century, Galileo Galilei, he gave the basic concept of fall. Actually, when you throw something which is heavier or lighter, they will come at a similar speed. Actually, not the heavier part will go more than the lighter part. That was the first basic invention by him. Then we all know he gave the Galilean system that we know. It was simply the system which says that every planet moves around the Earth, around the Sun. Before that, the concept was the Earth is in the center of the universe and everything revolves around the Earth. So he fought for the principles of science, and for that he was punished also. And his words were, which are very famous, appear the movie. It means yet it moves. Even after punishment, he stuck to the truth, yet it moves. So similarly, a concept has been into our mind, which has been followed wrongly actually, just like a commandment basically, that we should not use epinephrine in hand. That will lead to gangrene in the hand. So this is concept basically was given in 1944. The book written by Sterling Bunnell, in where he gave this that we should not use the hand. And this principle has been followed by hand surgeons and different surgeons for last 60 years, as it has been given or commanded by some supreme thing. But if we see during that time, 1944, the drug used was procaine. That was highly acidic drug. And lignocaine was invented in 1948. So even when this picture came into his mind, the drug was procaine, which was highly acidic and which was being used for that leading to gangrene. So at that time, 1946, phentolamine was given as an antidote. And if we see whether I am right or wrong, I'll just check myself over the literature review. If I just go into this, this is a search on the Google. If I just type here whether the use of adrenaline in hand is a myth. So what search that will lead to? This is a black and white thing actually which is going on. So if we see there are numerous papers now that the use of adrenaline in hand in combination with local anesthesia has been proven to be safe. There are numerous articles, and if we see there has been discussed few advantages also. So the group of surgeons, those who have come to that part were in early 2000 actually, and then this concept has been used. So how to use the adrenaline in hand, the local anesthesia? I'll call Dr. Rajesh to throw more light into it. Thank you.
Good evening, everyone. Now, for a hand surgery, what things do we need? So, first thing is that patient do not have any pain. For that, we have anesthesia. Next thing we want is no movement without control. We want some movement during tendon repairs, but that unwanted, uncontrolled movement that we do not want during the surgery. We also need a bloodless field to do delicate procedures in the hand surgeries on nerves and tendons. For that, we have tourniquet. This overall will give the patient a good experience. There is a different type of anesthesia ranging from sedation to general anesthesia. Then in local anesthesia, the problem is bleeding. Regional anesthesia traditionally has been used in most of the hand surgeries, and it will give no pain. If there is no sedation, then the patient will be awake. But for that, we also need a tourniquet. So the problem with regional anesthesia is that it will, during the induction phase, there will be needle pricks that will cause pain, motor palsies, Then in the pre-operative evaluation, patient need EKG and other lab investigation, drugs monitoring, operating room sedation. And also there are certain complications that are now damage systemic toxicity and more severe phrenic nerve. So in hand surgeries, in limited cases only, we need general anesthesia, like in complex hand surgeries involving brachial plexus and free transfers. Also in children, we cannot give we cannot operate them without general anesthesia. We also need inpatient department and big operating room for general anesthesia, and it is also associated with certain risk factors. So now coming to the tourniquet, there was a paper published in JBJS Journal site telling about the complication associated with the tourniquet. With tourniquet, there is tourniquet site pain. If it is applied for more than 2 hours, then it can also lead to nerve and muscle damage. Other complications are associated with skin problems like blisters. If tourniquet applied for prolonged duration, then nerve damage because of prolonged duration, and also in some cases because of prolonged application of tourniquet, there can be cardiac complication. So now there are worldwide the dental procedures are being done under local anesthesia only. So it is completely safe. The major myth associated with epinephrine is that in the end arteries, like in finger, it is associated with complications like necrosis. So in 2001, there was a landmark paper by Denkler et al., and it justified the use of epinephrine even in case of hand surgeries. Later, 2005 and onward, Donald Lalonde then popularized the concept of Wallen in his text, and he also published multiple articles and then popularized this technique. These are multiple papers from the same person. Now I would like to invite Ritvik sir for next part of this presentation.
Good evening, esteemed faculty and colleagues. So, like Volent, what is Volent? It is wide awake, local anesthesia, and no tourniquet technique. So, there is no intravenous insertion, no monitoring of the patients that is required, no routine pre-op tests or any fasting that is essentially required. Only buffered lignocaine with epinephrine is injected in a tumescent fashion directly into the area of surgery. And this technique is known as Volent. It can be performed in an outpatient setting or office with enough sterility and safety. So Banal did doing hand surgery without a tourniquet. He said that it's like repairing a watch under an ink pot because of the amount of bleeding that can happen. You won't be able to see the small structures that is present or essential structures that are present. So the major stumbling block of local anesthesia technique was the tourniquet site pain. So we had an alternative that is epinephrine, but use of epinephrine in the early 20th century was associated with a lot of finger necrosis, and that is the fundamental that was challenged in the whole study. So do not use epinephrine in digital block. Is it a myth or a truth? So in like my colleague before me said, there was a landmark article in 2001 when Denkler et al. Reviewed around 120 years of literature and found that majority of the cases there was no lidocaine with epinephrine used, and it was mostly prolocaine with warm water soaps that were used, which might have with procaine, which might have led to the necrosis rather than epinephrine. And the myth states that epinephrine is not state, which it originated a long time back. And at that time, the local anesthetics were different, and maybe procaine was the actual person to blame, but someone else took the blame for it. So how does Volent work? How do we prepare this? We take 2% lidocaine with adrenaline into 5 ml into a 10 ml needle. Then we dilute it with 1 ml of sodium bicarb, so that's to bring the pH to around 7, so that it helps with prolonging the action of the lidocaine and also avoiding the stinging sensation that may be associated with an acidic lidocaine. Then we dilute it with saline up to 5 ml, and then we give the anesthesia in the site, surgical site. So this is a video that demonstrates, her giving voluntary.
Around 5 ml. Just put one in between. Yeah,
Three noise to the patient, so that bypasses the whole initial pinch of the pain, and that is the only pain that the patient feels. And we inject around 5 ml of volant in the site.
only pain that
So patient education also during the whole process is also important. And we are able to tell the patient, and the patient, as you can see, the patient only felt a small pinch. So after a while, we can see blanching in the area where it was given. That's when we know that it has worked. And we did study names where we did comparison of hand surgeries that was performed in similar duration under volant and general anesthesia. We compared patient-related benefits, patient satisfaction, and cost efficacy. This was an ambiguity observational study during 2000. The data was from 2015 2021, and there was around 542 patients under volant and 216 patients under general anesthesia during similar period of 4 years. So we included patients over 18 years in the prospective group who were willing to participate or who have already undergone surgery under volant. And in exclusion, we had excluded patients who have uncontrolled hypertension, uncontrolled diabetes, uncontrolled peripheral vascular disease, and any history of CVA, epilepsy, and coronary artery disease, and patients who are not willing to consent. So this was a performer that was used for the daycare volant surgery done, where we essentially looked at the risk that the patient have and their consent along with the relevant details of patients. The comparison between volant and GA, the overall sex distribution was comparable between the two groups. And the age distribution was also almost comparable among the patients that were done under both groups. The major problem in any hospital would be the wait period that the patient has to get a surgery done. And we calculated it as the time elapsed from the patient registered for surgery till the actual surgery date that has happened. And this was an example of one patient, a recent patient. The patient registered in OPD on 2nd, and after that, on patient was given advised on 3rd. Patient had necessary investigations, so patient was advised surgery on 3rd, and we were able to give a surgery date of within 7 to 8 days. Whereas similarly, a patient who came to us on May, the similar patient, the wait period was around 4 months when the patient had to get workup under for general anesthesia. So this was the graphical representation of the patients in the study that was done. Majority of the patients had a wait period of less than 30 days to get the surgery done. Whereas in GA, they had to wait at least 1 month to 6 months, depending on the slot and their comorbidity, etc. So hospital stay was also taken into account. It was the amount of time spent in the hospital for surgical intervention. It could be from the time of admission till the patient was discharged. And since majority of volant cases could be done as a daycare surgery, majority of cases were able to get themselves discharged within 6 hours of making their admission slip. Whereas GA case, general anesthesia cases had to wait for at least 24 hours to a maximum of around 72 hours. So that was a major amount of time that patient spent in hospital. And when we looked at immediate complications like nausea, vomiting, or sore throat because of GA and any muscle pains or chills and shivers that patient had, only 3 patients in volunteer group had some sort of immediate complications within first 2 hours of any nausea or vomiting. But around 119, almost more than 50% of patients in GA cases had. So now to talk about cost analysis, I would like to invite Ratnesh sir from hospital administration.
Good evening, sir. Good evening, all participants. So, a part of this was calculating the cost that was incurred by the patient and the hospitals. For the patient's expenditure, the admission or the bed charges, and the preoperative investigation costs, if any, that were required, were taken. And from the hospital's perspective, the disposables that were used in form of gloves, drapes, or gowns, and the anesthetic agent that was used. These were the cost heads that were included in the study. So, as it is evident that minimum waste is generated during a violent case, only 2 drapes are required. And in a GA case, proper surgeon and OT assistant scrubs are required, and draping is extensive. This not only has an economic impact, but it also has environmental considerations. Nearly around 4 to 5 kg of waste is generated in a major surgery. The second part, anesthetic agent, the cost per patient in a violent case was nearly 100 to 120 rupees, while in GA case it was at least 400 rupees. And if we look at the admission charges, as Dr. Ritwik mentioned, that these cases are usually discharged within 9 hours. So they just have to pay the daycare admission charges, which is 60. In a GA case, if we take 3 days on an average, it will be amounting to 165 rupees in a general ward. Investigations, most of these patients did not require any special investigations, and the average that was calculated was around between 0 to 200 for each patient. While in GA case, the investigations that the patient they had to get done were ranging between 1100 to 1500 per patient. Similarly, consumables, just 50 to 60 rupees of consumables in Volent, and 3 to 400. Anesthetic agent, as I mentioned, 100 and 400. So the total cost comes out to be around 200 to 400 for Volent cases, and around 2000 for GA cases. Most of the Volent cases, they had to pay less than 600. So if we look at the cost saving for nearly around 200 patients, if we take a conservative estimate, around 5 lakh rupees could be saved in from the pocket of the hospital or the patients over a period of 4 years for only these cases which have been studied. And this does not include the indirect cost that the patient incurs, as well as the manpower costs that are involved, because it's a relatively smaller surgery. That is the cost estimate. Thank you.
So, coming to us, our college being a teaching hospital, it was also looked into whether this particular change that it involve help residents in their role during surgery, because of the we were able to do around twice the amount of cases during similar period, and in some cases, in violent cases, the residents were able to do it as first surgeon and as first assistant in 60% of cases. Whereas in GA cases, the trend was a little bit opposite, where they were second assistant in around 65% of cases. So this is a graphical representation of the same about the amount of cases that were able to be done, and the influence of Volent in resident learning. Staff requirement, there were around 0 cases where GA patients where we did not require a staff. In around 200 cases or 50% of cases, we could do the surgery without a staff, where they just set up the table and the surgeon and one assistant could do the whole procedure. And this was like the pictorial representation of how a similar case in GA and Volent goes. There was around involving 35% patients in Volent were operated without any requirement of staff during as an assistant. And time to next meal is also important for patients, and we calculate it as time elapsed from exiting the operation theater to having a full meal, and as informed by the patients. And if we look at that, majority of the patient had their next meal within 2 hours. Maybe because of complications, maybe because of the sedative effect of GA, patients have taken longer duration to have their next proper meal. And return to activities, we have calculated it as time elapsed from exiting the operation theater to the time when the patient could do some activity. It could be going to the washroom, or it could be changing clothes, etc. And majority of the patients, the overall stay was less than 6 hours. The majority of the patients in Volent group could do all of this in less than 2 hours, whereas GKs have taken more duration, or double the time, or almost 3 times the time that is required than Volent cases to return to activity. And we asked the patients about their satisfaction and how they felt about this anesthesia, and would they get the same surgery done in similar anesthesia or not. 99% of patients were satisfied. The 1% of patients that may be also because of the fear of general population of seeing surgeries or seeing a little bit of blood, etc. But there was a small 1% of population who said maybe they would consider. But 99% of patients were satisfied and would have preferred the same modality of anesthesia for surgery. Now, this was a representative image of one surgery that was being done in Volent. You can see one surgeon, one assistant who's a resident, and one assistant. Patient can even see and see the movement or see the effect that is required. This here you can see the scene.
बंद करो, खोलो, पूरा बंद करो, बहुत अच्छा, खोलिए, ये करके दिखाइए.
The patient, but also for the surgeon. Surgeon can also know, but in the regional patient may not be able to move their hands, and we might be able to know a little later. This was a patient who had tenosynoectomy done, and he had a little restriction of movement, and here he's able to, he himself can see how much movement is possible on table, and this will also help the patient in post-op rehabilitation in achieving that particular amount of movement. And the types of surgeries done, these are 5 major bony procedures that were done under Volent. Mallet finger, scaphoid fractures, metacarpal phalanx fracture, interphalangeal dislocation, and even non-unions of phalanx were done under Volent. And soft tissue procedures, there are a wide variety of cases that was done, including even post-burn contracture, differential release, carpal tunnel syndrome, decurrence, trigger finger, glomus tumors, and GCT of tendon sheath could be done. And we could almost achieve an incision of around 6 to 7 centimeter, and this was a fully reconstruction that was done. We could even see the tendon gliding under our reconstruction, and this was the amount of incision that was done for a tenosynoectomy. So the patient, we were able to achieve this for patients using Volent in hand surgery. And this was a scoring system that was done, which was a lead-in perioperative patient satisfaction questionnaire. That was mainly distributed as 3 subheadings about amount of the patient satisfaction with respect to amount of information that they have received about surgery, the fear and concern they had, whether they were addressed or not, how well they were addressed, and the patient interaction that had between staff and the patient. Could be doctors, could be the nursing officers. So the main, we had around 21 questions, 4 questions in information, which was how well the operation was explained, the amount of information about the operation, the explanation about the operation, and explanation about the stay in operation theater, and amount of information about your stay in the overall stay. So then any operation theater is a daily job for us, but might be intimidating to any patient. And like being awake during operation, is that a concern? Seeing the operation theater, does it bring any fear? Are they these are addressed or not? Pain during surgery, pain due to anesthesia, has what is their fear and how well they are addressed, and how happy they are about Volent or GA. In patient satisfaction, it was mainly about the interaction and the comfort that the patient have had We had around 13 questions for that about their insecurities and their privacy being taken into account, and how were the staff, were they respectful, were they polite, and how understanding were they about their fears, and how well they could pay attention to the patient, and this overall shows their patient satisfaction. And there was, even though GA cases also had similar scores, there was a statistically significant difference between Walent and GA about the overall satisfaction. In the information group, Walent group around 87% satisfaction and GA group at 84. Fear and concern patient interaction could also be because of the interaction with anesthetist. They could tell the patient about gloom or doom because of any sort of anesthesia that is being given, rather than any local anesthesia. And overall satisfaction, there was a statistically significant difference, though the numbers are a little bit compared, 88 and 87%. So, like, what are the surgeries that can be currently offered in the current setup in all over the world? So this is an article that was published in 2022 from Brazil, which said that they were talking about Walent techniques in percutaneous scaphoid osteosynthesis, for which we generally give block for the patient, or successful tendon reconstruction with Walent, or for hand wound exploration in isolated conditions. In 2000, that was an article in 2023. In 2022, there an article that said how to start Walent practice in South Africa. That is how well it was getting popular in hand surgeries. So more than the government setup, Walent can also be extended into in private sector, where surgery in a non-OT setup, in a minor OT setup, as an daycare surgery, and reduction in manpower, the amount of money and the patient has to spend, how easily it can be done in a resource poor condition, and how well it increases resident training in hand surgeries, and overall increasing the turnover of cases almost by double the number. So this was a case where you can see that
very good, very
पूरी
good.
ताकत लगा मोड़ने की गुड
we are on table, we can tell the patient to achieve the amount of movement that can be, and it can actually be beneficial for the patient knowing that how much movement he is able to make, and it could help in rehabilitation, and surgeon can also know how much effect it has come by his surgery. So concluding, sir, there was significant difference in hand surgeries done in Walent and GA in terms of time that was taken for the surgery to actually happen, to the hospital stay for the patient, to him or her having the next meal, to the cost of procedure being incurred by the patient and the hospital, to the ancillary staff requirement. There were comparable overall satisfaction rate, and the idea of daycare surgeries is getting popular, especially in orthopedics and in hand surgeries also. So maybe to conclude, I'd say that adrenaline may be a boon rather than a bane, as one seen in hand surgery.
Thank you, Dr. Ithwik. So, as we see, adrenaline in hand is rather a boon actually. So, it has increased the number of cases. Patients have less waiting time. Patient satisfaction is better. We are able to see actively in the operation theatre directly how much good the reduction is, how much movement patient will have. Even the patient education, if we try to educate the patient inside the operation theatre, that you should move the hand like this. It will move up to this point. Then they will move it. Definitely they will move it. That gives them the confidence. Even the OT side of education to the patient, you just try to teach them, you should keep it elevated. Don't hang it. You may have numbness once you hang it. How to protect the hand. So that kind of education can be given inside the operation theatre also. That's why you have to give extra time before taking the patient to the OT inside the ward or inside the OPD or before that. So that saves time also. And apart from that, if we see, everybody will say spend as much as possible. But I am saying save as much as possible, because saving is where you will have that money can be utilized where it is much more needed. So it's rather the opposite thing. Save here and spend somewhere where it is more necessary. So this is the judicious use of the money rather than spending it as much as we want. So thanks a lot. I just request Dr. Ranveer sir to conclude it.
Actually, the anesthesia machine, manpower, anesthesia, consultants, residents, technicians, everybody. That's a big cost to the event. So to include that cost, difference cost of it would be much higher. In most of the these practices, like human intervention surgery, because they start the patient up. That is why you have separate outpatient and daycare. Daycare center is more like a medical center where the patient comes, undergoes major procedure under protocol. Protocol is one failure that we absolutely stop. You don't use protocol because of the past. Protocol is not this patient will after surgery need to where he has a cup of tea and that and sleeping. And for some time it will be all goes. So you can see what kind of so these are the advances which were initiated by some surgeons, promoted by insurance. This is one advancement where insurance services are there. It's purely by surgeons. So nothing actually plus bicarbonate. See, when we read pharmacology, we were told you want to do IIT perhaps, you can't use the lidocaine will not be needed because the pH is the same as for so you enhance the action of also you're getting this is the advancement we have. I think we can promote it for surgery. So we promote it that. There are also how much can you get? But the total amount of 55 if you know that. It's based on weight. We have taken